And good morning, I'm Dr. Deuk. We are streaming live from Duke Spine Institute, Surgery Center Viera, where we do our surgeries. It is September 10th, 2024. And tomorrow is the big day, 9/11, we all remember. So our patient is here because he's having horrible back pain in this area, but he also has leg symptoms that go down both sides. He has several discs that are damaged, the L5-S1. He has another disc at L3-4 that's herniated on both sides and pinching the nerves going down his legs. L2-3 is completely collapsed, but it has an annular tear herniation, which is causing back pain. What are we here to treat today? Lower back pain and leg symptoms, lower extremity, we'll just call it lower extremity pain. Based on his MRI, I think these 3 discs need to be treated for back pain. These 3 discs needed to be treated for pinched nerves going down his leg. He also has pain in the SI joints on both sides. We're going to fix that as a second procedure. This is the sacroiliac joint. Our patient is sleeping nicely right now, and we're going to keep him that way for the very beginning until we get our needles in position. Then we'll do a discogram and confirm the discogenic pain. If you have questions, type them up. We'll be happy to answer them for you. In the meantime, since we're talking about causes of chronic back pain, would you mind showing our audience the video about the different causes of back pain?
Of
because
course.
There are 30.
Oh.
Meanwhile, we'll get started. I'm Dr. R. Deuk with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Deuk laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deuk plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Deuk piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deuk. Thanks for joining us. Welcome back. So you can see from our animation that there are many causes of lower back pain, actually 30 causes that are, I would call, common, but they're not equally common. Some are more common than others. The disc annular tear, which is what we're fixing right now, is the most common cause of chronic back pain. It accounts for 85% of chronic back pain, and the best treatment in the world to fix it is what we're doing right now. It's called the Deuk laser disc repair. It's the best treatment because it is the least invasive, it is the safest, the fastest recovery, and the most effective treatment in the world for back pain. 99.6% pain relief from disc pain. However, it doesn't work for other types of pain like facet pain or SI joint, which is why we have to do treatments for those separately. But we're going to be treating this patient's facet pain and SI joint pain as well, just not at this moment. We're going to start with the discs. Okay, I need to get around this big facet joint. It's arthritic. We are going to be treating this facet joint later with our Deuk plasma rhizotomy procedure, and then shot. All right, let's get an AP. The other thing about the surgery we're doing is that you don't lose any blood. This is a few drops, but if you have open back surgery, like a fusion, you're going to lose liters of blood potentially. And your body only has about 4.5 liters of blood on average. So if you're losing a liter or two, it can be very dangerous. Okay, we're trying to get to the L5-S1 disc, and then we're going to get to the left side. How is he doing, doctor?
Doing very well. Check to see how.
Before I go,
My friend, you okay? Okay, we're going to ask you some questions, all right?
AP.
Is that okay? He is awake and responsive.
That's wonderful. Thank you so much. I think we can fix the orbit there a little bit. We use the X-ray as a navigational tool. You have to have a good quality X-ray machine in order to do that. And our X-ray machine is top of the line. You cannot do better. All right. So we're bringing that L5-S1 needle into position. Shot. Good. And I like what I'm seeing so far, but it is not easy because there is a little bit of slippage there, 5-1. Let me know if you're having any pain, okay?
Are you having any pain, sir?
I think I'm going to go a little
Are
lower.
you having any pain? No.
All right. I know you're not at this moment, Sean. Come on, Jordan. Stay with me here. But you might, so let me know. Sean? Yeah. This is the hardest disc to get to. Just let me know if you're having pain. You feel it in your back? Yeah? I can't. You got to tell me what he's saying.
Are you feeling it where? In the back of the legs? What's that? Leg.
Where in your leg?
Nowhere.
Nowhere. Perfect. AP, that looks really good. I'm very happy with that. What was it, 3, 4?
Yes, sir. Yeah,
You might feel a little poke. Shot. Oh, it's perfect. Okay, lateral. So you can see his spine has some scoliosis, twisting. We're not here to fix that. It doesn't need to be fixed. It's not necessary to fix it. But we do want to get rid of the back pain, and to do that, we need to treat the disc. Now, he's a local. And what I mean by local, he's from Florida. He's from the Space Coast. So he's probably about 30 miles away from where we are, maybe 40. And we do get some local patients. I was talking to him and his wife about it earlier. You know, Titusville is named after the Titan rockets. And, you know, in the 60s, there was NASA has always been here with respect to the rocket launches. And Titusville was sort of their hub, their center, where all their astronauts and engineers lived. And I say this because I just watched a movie called Fly Me to the Moon. Has anyone seen that? I mean, it's a great movie, I got to admit.
Do you know why they chose the Space Coast? I heard about this. Why they picked it to be the Space Coast.
Yeah, I know why they chose the Space Coast. Let's see if you know why. AP.
Okay. I heard because of the way the weather patterns are.
It's not the weather.
In the middle of Florida, it's the best for the rocket.
That's not the reason.
Not the weather pattern?
Believe it or not, it's not. The reason NASA was chosen, Cape Canaveral was chosen, is because of the Earth's rotation. And they're able to get 10,000 pounds more payload on each liftoff because of the location with respect to the rotation and the gravity. That's what I was told by NASA. Because I actually worked over at NASA as a doctor for them for years.
So it's the rotation and the pattern of the
It's somehow it allows the rocket to get 10,000 pounds more payload than if you were to put it, you know, in another location like
So
Texas.
it's up in the atmosphere, it gets a better access.
Anything there?
How are you feeling?
Is that okay?
Any pain in your legs? Huh? No.
It's
No
a
pain.
bilateral 3-4. Everyone agree?
Great right there. He's not feeling.
Yeah. All right, great. You're doing awesome. We're going to put you to sleep in a minute.
Yep, you're doing really well, sir.
All right, so folks, we've placed the 4 needles to fix the 4 tears in his disc that are causing his back pain. How long have you had back pain for?
How many years, tell us? 20 years.
30 years.
Oh, 30, sorry. 30.
30 years. 40?
40 you just said.
Sorry.
What do
40,
we have written on
41 years. Yeah, but it's probably been bad the last 10, but he's had it for 41 years. Folks, he's had back pain for 41 years. Common for us to see patients with long-term back pain. That means he injured his disc 41 years or more ago, and he has discogenic back pain. It's called discogenic because it comes from the disc. And the disco is the disc part, and the genic is genesis or creation, so the disc is creating pain. And I believe it's coming from these discs. Are you comfortable? Any pain? How bad is that on a scale of 1 to 10?
Give us a number.
10 is the worst pain.
10? 10.
Is that where you get your back pain? 10 over 10, and that is L2-3. All right, is it better now? Okay, so we just tested the 2-3. He said it's 10 out of 10. You could probably see his back arch up. How bad is that on a scale of 1 to 10? 10. All right. Folks, is that where you get your pain? Good. So we have concordant pain, 10 out of 10 at 2, 3, 3, 4. You guys got that? You can see the tear. Jordan, show us the tear on that disc. Henry, you see this tear?
Yes, we do.
So the dye is the black stuff, and it's injected into the middle of the disc. And Jordan, show us where the dye should be. It should only be where Jordan is circling, the middle of the disc, called the nucleus. But show us where the annular tear starts. Right there. Yeah. That's where the tear starts. And look how long it is. It's about 3 centimeters. And it's the jelly, which the black stuff is highlighting, stuck in the tear that causes the back pain. And we discovered that at Deuk Spine Institute. We're the first in the world to ever discover it. And that's why we do the laser surgery. Because we can actually get rid of the back pain from a disc herniation or disc injury with the laser surgery without having to take the disc out, without having to put a cage or fusion, metal, artificial bone, bone graft, cadaver bone, fibular bone. I mean, all these invasive spine surgeries being done that don't work, this is the surgery that works, and it's the future of spine surgery. All right, any questions?
Yes, we have a couple of questions. This first one coming from...
Wait, before we take it, I'm going to do one more thing, and I will take your question, because we're almost done with the discogram, okay?
Copy that.
Are you comfortable? And then we're going to put our patient to sleep. How bad is that on a scale of 1 to 10? What do you say?
What number?
I think you said 10.
10.
Is that where you get back pain?
Yes.
All right, another 10 out of 10, concordant. The C stands for concordant. Concordant means that's where he gets his daily back pain. So I've just confirmed that 3 discs in his back are the source of his chronic back pain. I made that diagnosis before I had the discogram in clinic. When I saw him in clinic, I actually may have done it on Zoom with our MRI review. And I just confirmed that diagnosis with the discogram, confirming that there are 3 discs and each one causing 10 out of 10 pain. We're putting him to sleep now so we can start his real surgery. Any questions, Henry? Let's take some of the questions.
This first question coming from John on YouTube, asking, if you laser the herniated disc around the
John.
nerve and alleviate the pain, will the annular tear in the disc heal if there's still herniation coming out of it?
Hey, great question. So if you laser and there's still a herniation coming out of the tear, will the tear heal? It's hard to say, but generally the tears heal after our surgery and patients don't have any pain. So the evidence that the tear is healing is that the disc pain is gone. And if you have a different source of pain, for example, not disc pain but facet pain, then it's your facets that are hurting, not your disc. Can I proceed? So let's show our audience, Henry, what
Yes, sir.
disc pain looks like. Wipe.
Copy that.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals.
All right, welcome back. You can see, good. You can see from our video that the disc is causing back pain because there's inflammation in the tear. And by going in with the laser, we clean out the herniation stuck to the tear. We get rid of the source of inflammation in the disc. And the disc will heal, but it takes about a year to heal. So if there's still little bits of herniation, can the disc still heal? I think it can, but if the disc is hurting, then it's a clear sign that there's ongoing inflammation and it needs treatment. I hope that answers your question. Okay, we are placing the dilator in the disc through the foramen. I'm now going to place the tube that we're doing the surgery with. All of this equipment is FDA approved for this surgery. It's designed for spine surgery. It's designed for this surgery, and it's approved by the FDA. So everything we do here is FDA approved by the Federal Food and Drug Agency. And we've been doing this very surgery now for 18 years. 18 and a half years almost now. Going on 19 years. All right.
We have a few more questions.
I'd be happy to take your questions.
Next one coming from Brad on YouTube,
Hello, Brad. Welcome to our live stream.
asking, why do some posterior cervical fusion closures end up with a midline divot of the skin and muscle?
Yeah, Brad, great question. They all do, except for laminoplasty. Laminoplasty, the surgeon is leaving the bones and ligaments in your body, so you don't get that divot. But anytime a laminectomy is done, you're removing the bones that are over the spine in the back of the neck. You're going to have that divot 100% of the time. And that divot, along the scar line is just where the old material was pushing out, and now it's gone. It's pretty standard to have that. Laser? Great question. But that's divot is where the lamina used to be, where the spinous process used to be. They're gone after a PCDF.
We have another question coming from Essential Advantages on YouTube,
Essential Advantages, welcome. Thanks for joining us today.
asking, I have limited range of motion when turning my neck, but no longer any pain. You suggested the rhizotomy and DLDR for me. Will it increase my range of motion?
If you have zero pain, then it's unlikely it would improve your range of motion. But what's probably happening is you have facet pain, if I diagnose you with facet pain, and your mind is not allowing you to rotate your neck all the way to the side because it aggravates the pain in the joints and the arthritis. So I think, yes, you still want the rhizotomy treatment for facet pain because that pain is going to come back. And unfortunately, the mind works in such a way that subconsciously it's limiting your range of motion because you don't want to generate that pain again. You want to avoid that pain. We call it guarding. It's a very common phenomenon in orthopedics where the patient's mind does not allow them to move a certain joint that's painful, not because it's painful, but because they don't want to bring the pain on. They don't want to recreate the pain. So they end up, living life with limited range of motion, which is not good for you. It's not good for your muscles. It's not good for your functionality, and the facet pain will come back. So I would get it fixed. It's a very good question.
Next question coming from Brad once more on YouTube,
Sure.
asking, have you ever heard of digital motion x-ray?
Of course. Yeah, digital motion x-ray is what chiropractors do. And the reason they do it is because it's not covered by the insurance. But it's useless in my opinion. And it's just, they show you things like subluxation of C1 on C2, which by the way is normal. And they tell you that because you have that subluxation, you need treatment from them for 6 weeks or 8 weeks. I don't have anything against chiropractors at all. I just have a problem with deceitful, lying, and cheating people. So I wouldn't waste your money and time with digital motion x-ray. You will never find a neurosurgeon or a respectable spine surgeon ordering a digital motion x-ray because it's not a I want to say validated diagnostic test. By the way, these are all pieces of herniation I'm taking out, the blue stuff. And I use the laser, but these are big chunks. And the big chunks are not good for the laser. The laser would take an hour to break this up. So rather than taking an hour surgery, hour for each one, I use the grabber. So the surgery is done with two tools. One, the laser, the other is the grabber. And the name for the grabber is called the pituitary rongeur. It's an endoscopic pituitary rongeur. And this surgery you're watching is a full endoscopic transforaminal Deuk laser disc repair. And you won't find it anywhere else in the world because it was pioneered here at Deuk Spine based on the source of pain. We discovered what causes people's back pain here, confirmed it through this procedure. And we've been doing this for 18 and a half years now. We've discovered the disc, specifically this little tear in the back of the disc where there's this herniation stuck in it. This is the cause of their back pain, patient's back pain. 85% of patients with chronic back pain. So if you know somebody with chronic back pain, just say 85% of the time it's coming from the disc. And it may be more than one disc. It could be 2, 3, 4, and the average is 2.5. All right, the average is 2.5 per patient. That's what we've discovered over the years of treating thousands and thousands of patients. Henry, you have any more questions?
At this moment, there are no current questions, so in the meantime, let's show the audience of how this procedure actually works.
I think it's a great idea. Thank you.
Of course.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes.
Sorry for interrupting your video, folks, but I had to show you what just came out of the tube. I was grabbing little pieces of the herniation, and look what just came out. That is beautiful.
Wow.
Henry, let's get this for the website.
Yes, sir.
Get it to Sanjay.
Copy
I
that.
want a really good, nice picture here. Okay?
Of course.
Right there.
Hold up.
You can see that thing is almost 3 centimeters. It's 3 centimeters long.
Perfect.
Okay?
Yes,
this
sir.
needs to go on our Deuk Laser Disc Repair website.
Copy that.
So that is the herniation at we're at 2-3, right?
That's right.
I mean, the disc is collapsed, but there was a herniation, and we got it out. And we were taking it out in pieces, but that's the biggest piece, and I wanted to show you guys that. We still have a little more to do here, but just for your viewing pleasure. All right, I apologize. Let's go ahead and start that video again
Copy
on
that.
how the Deuk Laser Disc Repair works.
Copy that.
And before you go, though, look at that inflammatory tissue in the annulus. That is the source of back pain, that pink stuff right there. By zapping it with a laser, you cure the back pain. We're the only ones in the world that do this, and we do it minimally invasive, folks. If you want to get rid of your back pain, come to Deuk Spine. That's what we do. And like I said, there's 30 different causes, so we got to figure out what is your cause. And a lot of people will come and they'll get their cause fixed, but then they'll develop another cause later on, and they have to come back. And we can fix the other causes as well. But the other causes are never going to be the same causes that we already fixed unless the patients do something like reherniate, which is very rare, only 1% reherniate.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Money first. Welcome back. And so the answer is yes, Luis, I want to do that. But I need to talk to our CFO because we have a lot of expenses and the revenue is not great right now. Yeah. But tell him I'm interested in doing it. Okay, welcome back. And I'm just talking to Luis about some equipment. So let's take the questions that we have while we finish up this L2-3 disc on the right.
This next question coming from Essential Advantages once more on YouTube, asking, when doing the DLDR for someone who doesn't have the pain anymore, then will it still show visible herniation?
Yes, of course. Yeah, the herniation is still there. The herniations don't go away. That's a misnomer, misunderstanding, a falsehood, fabrication. Your herniation is still there. It's just a matter of time before it becomes symptomatic again. Okay? If you have a fracture that doesn't heal and you sit down and rest it for a few weeks, it doesn't hurt, but it's still a fracture. It's still there. And it's just a matter of getting up and getting active again. You're going to aggravate the fracture, and the aggravation is going to cause horrible pain, and then you're going to have to take it easy again. So with a disc herniation, you fractured your disc. It is a fracture. It is not a bony fracture. It's a ligamentous fracture, and ligamentous fractures are just as bad as bony fractures in the spine. Yeah. So you still need it fixed. Next.
At this moment, no current questions.
All right, we've shown our audience how a disc injury causes back pain.
Correct.
We've shown them the best way to fix it, the Deuk laser disc repair.
Correct.
And let's show them the second most common cause of chronic back pain, which is the facet joint pain. We're done here.
Copy that.
You might be able to see the nerve root. Turn it on. Yeah, the nerve is just there in that fat. So we're just below the nerve root. You can see the annular tear, scope off, is about 3 millimeters now. So it's shrunk already. And the reason it shrinks is we just removed the herniation from the tear. And because of that, the herniation that's stuck in the tear is gone because of the laser and the grabber that now the tear can close properly. That's really what it's all about, getting the tear to close properly. All right. Any questions?
At this moment, no current questions.
Welcome back. So we've just shown you the video on the facet joints and how the facet joints can cause back pain, because we're treating the disc right now, but we wanted to show you a second most common cause of chronic back pain, which is the facet joints. Patients with chronic back pain lasting more than 2 weeks, they have 50% of them, almost, it's 45%, have facet joint pain in addition to the disc pain. So that's almost half the patients will also have facet joint pain. Shot? All right, now we're going to go into the L3-4 and fix the L3-4. Shot? Can you move north a little, Jordan? Shot? Uh-huh. I'm removing the needle, leaving the guide wire. Next, the dilator will come down. We're going to use the same incision. This is a 7 millimeter incision, meaning it's a Band-Aid incision. So there's really no need for narcotic painkillers after surgery because we're not doing an open invasive surgery. Our patients do not take narcotics opioids, which are dangerous, after the surgery. Of course, if they were taking them before, they need to keep taking them. We're not telling them to stop taking their narcotics because they really need to wean off the narcotics. That's done with their pain management doctor, who will taper down on the dose over time. Typically, you'll cut the dose in half for a week, and then you'll cut the dose in half again for a week, and then you can stop altogether for narcotics. But we don't give patients narcotics with this surgery because the pain is minimal. Hold on. After surgery, you can see the small incision. Okay. Okay, now that went in pretty easy because there's a large tear in the back of that disc. We saw that on the discogram, right, Jordan? It was a huge tear. It was about, 7 millimeters, that tear. All right, that's good. We are now inside the tear. We're going to clean the tear with a laser. Okay? We always start in the deepest part of the tear and work our way out to the surface. That's the strategy. It's called the inside-out technique. It was developed by Dr. Anthony Young, who trained me. He was one of my mentors, teaching me endoscopic surgery. He's now retired, but he's the guru of endoscopic lumbar transforaminal surgery. He's, in my opinion, the best in the world at it. It was the best in the world. I can actually feel the needle from the other side. And my grabber got stuck on the needle tip from the other side. So we'll be able to see that in just a moment. So this disc we're doing from both sides. Yeah. And there's the needle right there. You guys see it?
Yes,
Yeah?
we do.
You see a flash of it right there? There
Yeah.
it is. Yeah.
Yes, we do.
So my grabber was getting stuck on that. See the tip of the needle? Now, this shows you how magnified the view is. It's highly magnified, very good view. This is the old system, right? They already picked it up? Are they going to give us a demo for that price?
No,
Brand new.
Yeah.
Warranty is how many years?
7 years.
How many years is the warranty?
7
7 year?
7 years.
They warranty for 7 years.
Yes, sir.
Oh,
Pretty good.
that's great.
Yeah.
Most medical equipment is a year, if it's new.
It's not like a standard. It's come with the.
Huh?
It's come with the price. It's not like a standard or you buy it. Or
I understand. No, that's great. I like that. 7 year, and we need to look at the warranty. All right, any questions from the audience? Luis, will you pull this needle back just a little bit?
At this moment, no current questions. So in the
That's good.
meantime, why don't we show the audience we show them what is facetogenic lower back pain. Why don't we show them how we cure facetogenic
I
lower
love
back
it.
pain?
Thank you, Henry.
Of course.
Great idea.
Facet joint injury is a common cause of chronic back pain. The inflamed facet tear generates pain signals. The best treatment for facet joint pain is the Deuk plasma rhizotomy. Inflamed facet joint pain nerves are destroyed. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Sprechen Sie Deutsch. Sprechen Sie Deutsch. All right. Welcome back. You can see, and Henry, the procedure you're talking about is the Deuk plasma rhizotomy.
Yes.
It's unlike any other type of rhizotomy out there. Most pain management doctors do a radiofrequency ablation. The problem with that procedure radiofrequency ablation doesn't work. It doesn't last. It doesn't work. It's got lots of issues. It's a relatively safe procedure, the radiofrequency ablation, and a lot of people end up getting it done 2 or 3 times a year by their pain management doctor for their lifetime because the pain never goes away. With the Deuk plasma rhizotomy, we come in and do the treatment and it takes the pain away permanently with one treatment. So that's the advantage. The Deuk plasma rhizotomy works and it lasts over the radiofrequency ablation. All right, any questions?
Yes, we just got a question from Bill on YouTube.
Hello, Bill. Welcome to our live stream. I'm Dr. Deuk Majin. This is Henry. We'll take your question.
Yes, they asked, what do you think of Dr. John Sarno?
Who?
Dr. John Sarno.
To be honest with you, I'm not really familiar with that doctor.
I know about it.
Do you? Dr. Berndes knows Dr. Sarno?
Yes.
All right, tell us. Huh?
S-A-R-N-O.
Sarno. Oh,
Sarno.
Tell me, what is
Yes.
Dr. Sarno, a surgeon or what?
I don't know what type of physician he is. I'm not sure if he's even
How do you know him?
but he
How do you know him?
He relates a lot of back pain to psychological past abuses, suffering,
I
issues,
see.
trauma, stress.
All right, so I'm hearing on the side here.
He was the author of the book Healing Back Pain, professor of rehabilitation medicine at NYU.
Okay, great.
Yeah.
He's dead?
Yeah, he passed
Oh.
away in 2017, 93 years old.
Yeah, sure. So here's my understanding from briefly listening is that Dr. Sarno believes that psychological stress, childhood stress, abuse is the cause of back pain, or makes back pain worse. So here's the facts. Certainly stress and anxiety and depression can make your interpretation of back pain seem worse than it is. But back pain is real. It has a real physiological origin, and we are treating it right now. The problem is with Dr. Sarno's era of doctors treating back pain is it's an error. It's an error era, meaning they did not know where back pain is actually coming from, and they treated patients like they were crazy. They had psychological basis to back pain. Back pain is not caused by psychological distress. It is a fallacy. It is 100% wrong. It is still believed by 95% of doctors that back pain doesn't have a source. There's no cause. It's psychological. There's no way to fix it. But it is wrong. That's why we're doing this entire program of broadcasting these surgeries. We cure back pain with this procedure. This procedure has nothing to do with people's psychological stress or their childhood. It has everything to do with getting rid of the actual source of back pain. So to summarize, psychological stresses, childhood, or abuse, it does not cause back pain. It may amplify the symptoms of back pain in the person. Each person's different, and make it worse. Or it can affect the way they deal with their back pain, the way that they live life and address their back pain. However, we have to stop believing that back pain is doesn't have a basis in a structural problem. It does. Literally, we can cure 99% of back pain here at Deuk Spine and chronic back pain, non-cancer, non-infection back pain. Okay, we're talking about people with chronic debilitating degenerative back pain. We can cure it. That's 98% of patients out there with back pain. We can find the source and cure it at Deuk Spine Institute. And that's what we do. We did almost 400 of these surgeries last year, and our patients in general are very happy. We have a 95% very happy with everything rate. We have a few patients that like to grumble because they have other causes of back pain that we never treated and they didn't want to treat because they didn't want to pay the money, they didn't want to have it done. They only wanted to have what they thought was important to get fixed, and they're second guessing the surgeon, which does happen. You all know that, right? We don't just go to the doctor and the doctor tells us what to do. We actually think about what they're telling us and we have our own opinion. And you're entitled to do that, you know? And I want my patients thinking for themselves and deciding for themselves. That's what makes them individuals. And I don't never want to tell a patient what to do, but I'm going to give my patients the option to treat. And it comes first by making a diagnosis. And to say that back pain comes from psychological stress is 100% wrong. It is certainly made worse with psychological stressors like anxiety, history of abuse, maybe depression, your interpretation of back pain, your understanding of back pain and its origin. So I agree that psychological factors are very influential on people's experience, personal experience of back pain, but I'm telling you right now, they are not the cause of back pain, and there is an organic basis to back pain. I can find it, and I'm probably the only person in the world that can, unfortunately. We need more doctors trained at finding it. I have other doctors that work with me that are, I would say, about 90% able to find the sources of back pain, ones that have worked with me for years in my clinic and understand my methodology. But identifying the cause of back pain is very difficult, and it takes a lot of experience and knowledge. And we have it here at Deuk Spine, but other doctors do not have it. Generally, they do not have it. So they're going to prescribe to the belief that, you know, people with back pain are either faking it or they've got psychological trauma or stress that's the cause of it. It is 100% not true. I will stand behind my statements. You send me somebody with chronic back pain, just do our MRI review, and I will tell you exactly where the back pain is coming from on Zoom. Okay? Now, obviously, the patient that I'm interviewing on Zoom has to have the back pain at the time of the interview, because I'm going to ask them to show me where the pain is coming from. So if they have 5 different causes of back pain and they only have 3 that they show me on the Zoom call, I can only diagnose the 3. I cannot diagnose the 5, because diagnosing the source of back pain is all based on the physical exam. And your physical exam is a moment in time in the patient's history. And if they don't have pain at that moment, I can't diagnose the source. It's impossible. So to aid me in the diagnosis, accurate diagnosis of back pain, I must have the patient in pain, having their typical daily pain when I interview them. Otherwise, I will not be able to diagnose the source of back pain. But it is not psychological. I can guarantee you that. And I've treated 10,000 patients successfully here at Deuk Spine and in my career before Deuk Spine with back and neck pain, and gotten rid of their pain successfully with our surgical treatments, not psychological treatments, okay? It has nothing to do with validation of pain. It has nothing to do with, you know, psychoanalytics or psychotherapy. We don't do that here at Deuk Spine. What we do is acknowledge the source of pain and treat it. And the disc is 85%. If you look at our new website, you go to lower back pain, which is the first big page, you'll see that there are the disc, the facets, and what we call other causes. And under the other causes, they're all organic causes. They are all like piriformis syndrome, sacroiliac joint, like this patient has sacroiliac joint pain. We're going to fix that next. Coccydynia, which is your tailbone hurting from inflammation of the ligament. And then there's fractures of the spine, of course. Saw a patient with a sacral fracture the other day in clinic, right? So they fell and they have a tailbone fracture. It happens, okay? So there are organic bases to people's back pain. We have to stop telling people their pain is in their mind. It is wrong. Certainly psychotherapy is important, and you want to treat their anxiety and their depression, and you want to make sure that, you know, you treat it appropriately. But once you get rid of their pain, a lot of those things normalize, and they get back to being a normal human being. Hopefully you appreciate the long-winded answer, but that is the God's honest truth. Almost done. You guys see the epidural space? There's some fat right there. You can see each fat
Yes, we
cell.
do.
This is the foraminal ligament. This is at the back of the disc. We are now done with the annular debridement. Once I take a few more blasts with the laser, we'll be done with this annular debridement, and we will move on to the next. Now, somebody asked earlier, Dr. Deuk, can the disc heal if there's some herniation? The answer is yes. We never get 100% of the herniation out. It's impossible. I always tell people I can get about 60% on average. Some people I can get 80, some people I can get 50. You only need about 50% of that herniation out to get the disc to heal properly, okay? And we've never had a problem with the disc not healing properly. We've had a 1% reherniation rate. That means 1% of our patients will reherniate, okay? And what that means is they push out another piece of herniation before the disc heals. Okay, questions?
Yes, got a couple more questions. This next one coming from Bill once more on YouTube asking, is back pain caused fundamentally by oxygen deprivation?
Dale, 100% no. Oxygen deprivation is not the cause of back pain. Absolutely not. Sorry. It's caused by inflammation. Inflammation, a natural process that happens in everybody's body that is part of your defense system, part of your rebuilding system. But the problem is the source of inflammation, which is the herniation stuck in the annular tear, the inflammatory system is incapable of removing it, okay? For example, if you take a thorn, stick it in your finger, it's going to get pink, red, swollen, tender. It's going to throb and hurt until you get the thorn out. Now, if you don't get the thorn out, you just leave it there. I'll get it. If you just leave the thorn there for weeks and weeks, it's still going to hurt, right? And every time you touch it, that thorn, it's going to hurt more. And that's exactly what a herniation is. It's a thorn in the back of your disc, except it's not a woody thorn. It's a soft tissue thorn. And your body is trying to get rid of it through inflammation, just like your body's trying to get rid of that thorn. But you can never, ever get rid of that thorn with inflammation. Your inflammatory system will never be able to remove that thorn. You must physically, manually remove it. And that is what I do with this surgery. I physically remove the herniation, the thorn that's stuck in the tear, causing the pain. We discovered that. I discovered this. I am the discoverer of this. And I've been trying to teach it to the world for the last 10 years, more than 10 years, actually 16 years. And, we're getting the message out, but not fast enough. So it's not oxygen deprivation. It's a foreign body that's stuck inside your tear. We are doing L5-S1 and big tear. I mean, that thing went in easy, right? I barely tapped it. Big tear, big pain. He had 10 out of 10 pain at this disc when we tested it with the discogram just a few minutes ago. So all 3 discs are painful, 10 out of 10. And what's important is they're concordant. Concordant means that is the patient's everyday pain that he gets every single day of his life whenever he does stuff. And I reproduce that pain by testing the disc. So we know the disc is the source. Okay, keep the questions coming. I'm happy to answer them. We're going to do the L5-S1 on the right. Then we're going to go do the L3-4 on the left. We'll be done with the Deuk laser disc repair. We're going to move on at that point to the bilateral sacroiliac joint plasma rhizotomy, which I developed and patented here at Deuk Spine.
This next question coming from Jerome on Facebook.
Hello, Jerome. Welcome.
Asking, we have seen that the act of lumbar puncture in animal studies can cause DDD. Are you in the disc when you are doing the laser? And can you talk about the act of puncturing a disc and how that is different to your procedure? Thank you.
Yeah, Jerome, absolutely. So first of all, Jerome, you're talking about a study that was published, which I 100% think is a fake study, unreliable, complete garbage, okay? But let's just take the study for face value for what it is. The study you're referencing basically stated that when the doctor took a needle and stuck it into a normal disc, that it caused the normal disc to deteriorate, right? That's the study. They didn't stick needles into deteriorated discs because they're already deteriorated. They stuck needle into a normal disc, and the reason they did that was because when you do a discogram the old-fashioned way, you do it with what's called a control level. And a control level is a disc that's normal looking on the MRI. But here's the thing. Number one, that's very subjective. What's normal looking, right? I get normal disc read MRIs all the time, but the disc is not normal. They're actually bulging. It's just a small bulge. But any bulge at all is abnormal. That means the disc is already injured. So if you're picking the disc adjacent to the disc that you think is painful, that is your control level, chances are about 90% it is not normal. Because whatever trauma caused damage to the disc you're treating as a doctor, it also caused trauma to the disc above and below. Because those injuries are traumatic, and trauma doesn't just pick one disc, okay? And that's evidenced by our studies, which found that the average patient with discogenic back pain has 2.4 discs as the source. That means it's not one disc, it's 2.4 on average. So a lot of patients with 2, a lot of patients with 3, averaging at 2.4, which is really 2.5. So 2.5 bad discs per patient. That study was really looking at one bad disc, and the next one they were sticking the needle in saying it's a control level, and oh my, look what happens later on when we stuck the needle and the disc degenerated. Well, the disc was going to degenerate anyway because it was already abnormal. It was already damaged. They just didn't pick up on it. And I don't know why they did. Here's the other thing. That study is funded by the insurance companies. The insurance companies are trying to scare doctors out of treating patients' back pain because they don't want to pay the bill. So how do you confirm someone has discogenic back pain? You do a discogram. Well, if they scare the doctors out of doing discograms and the patients out of doing discograms because they publish some garbage study that shows that the discogram is the cause of the back pain later on, people are afraid to get a discogram, therefore they can't confirm the diagnosis, therefore they can't have surgery. That is the true purpose of that study. It is an insurance-funded, supported study, okay? And I'll make one last point. Even if you don't believe anything I've said to you so far, let's just pretend that everything is legitimate, and you stick a needle into a normal disc, and the disc degenerates, right? Let's just take it for face value. That's what it is. Okay, well, we're not sticking a tube into a normal disc, are we? This is not a normal disc. This is a damaged disc, and it is a painful disc to begin with. So if I was sticking this tube in normal disc, yes, I would be concerned if I believe the study, but I'm not sticking a tube in a normal disc. I'm sticking it into a already massively injured and painful disc. That answers your question, I think.
We have a couple more questions. This next one coming from Bill once more on YouTube.
Hello, Bill.
Asking, why do you think so many other doctors are stuck in their own mental prison and won't answer questions like you do?
I think the answer, Bill, is they don't know the answers. That's why. They don't know the answers. I am not like other doctors. I used to be ignorant like other doctors. When I got done, all right, first of all, you got to know something about me. I was valedictorian in my medical school class, all right, at USC in Los Angeles. We're talking about one of the top 20 med schools in the world. And, you know, being valedictorian means I studied, I learned a lot. I know a lot about, is that me?
No, it's just
I learned a lot about medicine, okay? The only reason I'm saying this, not to brag to you, but to say to you, I'm not like most people. I'm a very good observer, and I'm a good learner, and I pay attention, and I'm always wanting to make things better for my patients. I'm always wanting to solve problems, whatever those problems are. So I approached pain, back pain, like it's a problem that needs to be solved, because it was. When I got done with my residency and I went to the #1 spine surgery, neurosurgery residency in the world, which was at the time University of Florida in Gainesville, I came out trained really well in the most advanced techniques in spine surgery. But I didn't know anything about this. This wasn't taught to us. We were taught that back pain is, nobody knows why you have back pain in patients, and that if somebody has back pain, call pain management. And the pain management doctors will come and they'll write them for narcotics, pain pills and anti-inflammatories, and do some shots with steroids. So that's how we treated back pain as spine surgeons back in the 90s and 2000s. Okay. And so I realized, though, after doing spinal fusion, hey, I can cure back pain with a fusion. So I paid attention to my patients, and I didn't do fusion to cure back pain. I did fusion because they had instability. They had pinched nerve, weakness in their legs, but they also had back pain. And when I saw the patients afterwards, I said, how's your legs? Good. How's your strength? Oh, it's so much better. Thank you, Dr. Deuk. And my back pain's gone. What? Your back pain's gone? I didn't know I can get rid of back pain. So I started to think about, why did I get rid of back pain? And why aren't we more of us trying to get rid of back pain rather than just treating it with pills and shots, right? So over the next 20 years, I actually invested a lot of time and effort into understanding what causes people's back pain, and I discovered the causes. And then I discovered the actual treatments that work. And not just treatments that work, because fusion works, but better treatments for patients, less invasive treatments that are safer so we don't have complications like pneumonia, heart attack, blood clots, all the bad stuff, infections, all those bad things that happen with fusion. So I didn't just want to discover the cure to back pain and neck pain, but also how to treat it better than what's available, like the fusion stuff, the artificial disc. So that's what drove me to where we are. We are literally 50 years ahead of the rest of the world in treating back and neck pain, 50 years. And it's going to take them, if they start today, 50 years to catch up. But if they actually listen to what I'm teaching them, they'll catch up overnight. But it takes a huge capital investment to buy all this equipment and set up a center that does what we do, because this is all stuff that most spine surgeons don't have. They don't have it, period. So they have to buy it. It's millions and millions and millions of dollars in equipment. And a lot of people don't want to take the risk of buying all this stuff and then not being able to use it and make their money back. Okay, so when I bought it, I bought my first bunch of equipment 18 years ago, 19 years ago. I took a huge loan out, millions of dollars from the bank. I took a personal guarantee. I had to basically would go bankrupt myself if I couldn't pay it off. So I took huge risk to be able to help people with these surgeries. Thanks. And most doctors won't do that, okay? And I did it because I believed in the technology. I believed it was helping people. It was the future. And I couldn't believe nobody else in the United States was really doing it. Dr. Anthony Young was doing it, but he was also a pioneer. And he was not, his ideas of fixing these discs like this with endoscope, it was revolutionary in the United States. And other doctors laughed at him like they laugh at me. But you know what? That didn't stop him from doing what was right for the patient. Because the truth is, as a surgeon, I'm here for my patient, not for other doctors. I'm not here to impress other doctors. I'm not here to convince other doctors. I'm not here to treat other doctors. I'm here to treat my patients. If my patient happens to be a doctor, great. Or a lawyer or a businessman, whatever, that's fine. Point is, I want to do what's best for my patients, not what's best for me as a neurosurgeon with my colleagues, which most neurosurgeons are more focused on how do I establish myself as a thought leader in neurosurgery among my peers. And the only way to do that is to conform to what they want you to conform to, which is invasive spine surgery. And I'm not willing to do that. I want to do what's right for my patient, not what's right for these companies that control the surgeon. So to answer your question, why don't other doctors take questions and answer them? Because they don't know what causes back pain. So why would they take that question? Why would they put themselves in that situation? Yes, doctors are ignorant about a lot of things. You're right. I am. I'm very ignorant. I don't know a lot. I know very little. But the truth is, we don't like to admit it. And certainly to our patients, we don't want to admit it. So a lot of these doctors won't take questions because they don't have an answer, and they don't want you to know that they don't have an answer. They're afraid of you, the patient, knowing that they don't know. Me, I'm not afraid because I realize I'm human and humans can't know everything, and I don't know a lot. So I will be the first person to admit I don't know a lot. I have no ego. I'm not an egotistical person. I'm a realist. I like to look at the reality. I mean, what I find is that if you accept reality, then you can find solutions to reality. If you live in a fantasy world, then you don't have solutions for reality. You have fantastical solutions that don't help, the real world. I want to help the real world, not a fantasy world. So I just gave you a deep dive into my mind, which is what these talks are all about. Deep dive into my mind. All right, next question.
Next question coming from Jerry and or Janet on YouTube,
Hi, guys.
saying, do you treat neurogenic claudication spinal stenosis?
Yes, we do. Neurogenic claudication is when people get leg symptoms like tightness, pain, discomfort, numbness, weakness. I mean, you pick your symptom, right? There's a bunch of them. But they all arise from the fact that the nerve roots that go down your leg from your back, they originate in the spine. They go out these little holes called neuroforamen. Those nerves get pinched when you're standing up, and they get better when you sit down. So neurogenic claudication is leg symptoms that get worse with standing and walking, but get better when you sit down. Do I treat it? Absolutely. This surgery right here you're watching at this very moment is treating this patient's neurogenic claudication. This patient, yes, we talk about back pain. He has back pain, but we're also treating his pinched nerves. The nerves are being pinched literally right where the tip of the laser is. This thing right here that I'm removing is the herniation, the blue stuff right here. It's kind of a faint blue. By removing this, it shrinks down the herniation that's pinching the nerve. The nerve is literally right outside this tube. If I were to look over here, that's the nerve right there, just in the fat, okay? And it's right outside the tube, and it's getting pinched by the herniation. So we are treating neurogenic claudication with this surgery. I don't talk much about it, but yes, it is definitely treated with the Deuk laser disc. This is the best treatment in the world for neurogenic claudication. The reason is we are exactly where the neurogenic claudication comes from. If you do a laminectomy, for example, they're opening up your back in the middle. Well, the nerves are not being pinched in the middle, they're being pinched on the side. And they're being pinched in the lateral recess and the neuroforamen. Go to our new website, deukspine.com, and I have a fax section, FACTS. Henry can probably put the link here in the broadcast, and it will link you to the spinal stenosis facts. And read them. You'll learn about spinal stenosis and what causes neurogenic claudication, but it's not central stenosis. It's not paracentral stenosis. It is lateral recess stenosis and neuroforaminal stenosis, which is exactly what's being treated with this surgery. This is your best treatment for neurogenic claudication. Next question.
Next question coming from Raj on YouTube.
All right, we are pretty much done. There's a little bit of herniation right there, just under the nerve root. I want to get that guy right there. But I got to be careful. The nerve root is just there. You can't really see it because it's buried in fat. That fat right there is where the nerve root is. And it's protected by the fat. And the fat also has another function besides protecting the nerve root, like giving it a cushion. How come my sucker's not working? I need my sucker working, please. The fat also provides energy for the nerve root. By the way, look at this, guys and gals. This is pieces of herniation that have come out of the tube and just kind of laying around everywhere, right? Because they come out in pieces. Scope off. All right, we're done with the right side, and I will take Raj's question.
Raj asked, hi, is a keyhole minimal invasive keyhole surgery not as good as the laser you use for disc repair?
Correct.
Also, is it possible that a normal MRI lying down can miss issues when you're in motion?
Yeah, great questions, Raj. Number one, is this keyhole surgery? Absolutely not. Keyhole surgery is where they drill a hole in your spine and they make a small hole. Oh, you do not want keyhole surgery. That is a microdiscectomy, okay? And you don't want doctors taking pieces of your spine out. That's just going to weaken your spine. Let me have a hemostat. So this is hold on. This is a 7mm incision. You guys could see we've had no bleeding, right? We had a couple of drops. Come on, guys. You should have a hemostat as part of this setup, for God's sakes. My wife told me don't yell at the staff online. She said go to a commercial and then yell at them. But I just can't help myself. All right. Here you go. You should always have a small mosquito available. 7mm incision. We're going to put 2 little staples. I actually screwed up the first. It's weird. I just screwed that one up too. It is really interesting. I can't understand why that's happening. This may be a defective stapler. So the stapler is supposed to put the staple out in the middle, and it's putting it out to the side. So that's 2 in a row that I've missed. So let's see, how can I avoid another miss? If I get another miss, we're going to get a new stapler. I just don't see. Can you wipe that, please? That would just be helpful. Okay. All right, that one we got because I overcompensated on the right. There we go. Done. Thank you. We're good. Don't open the next stapler. Okay, so what I was saying was this is not keyhole surgery, because keyhole means you're making a hole in the spine. They're going to take your lamina, your ligament, your facet capsule, your facet joint, and drill it away. It is invasive surgery. It's just another way of doing a discectomy. Don't fall for it. The second question was, remind me. Henry, are you there?
Yes, yes, sir.
Are you paying attention? The second question was?
Second question was also, is it possible that a normal MRI lying down can miss issues when you're in motion?
You're right.
Apologies on that.
The answer is yes, Raj. A lying down MRI, you're right. It is limited because people are unloading their spine. They're getting the pressure off the discs, so the discs, instead of bulging out, are bulging in, and you can't see them. So you're correct. That's why MRIs are not reliable at diagnosing back pain. You need a clinician who can interpret the MRI and figure out, where the source of pain is coming from. If MRIs told us where back pain comes from, then there would be nobody with back pain in the world, because the MRI tells you where it comes from. The reality is the MRI does not tell us where back pain comes from. Shot? All right, I may have to make this a little bigger. Let me see. This is going to be a 7mm incision, but I may have made it a little bit too small. But that's our bleeding. I mean, it's incredible. This is pretty much bloodless surgery. Shot? Okay, let's do a little num-num. Any other questions?
No current questions, but we do have a comment coming from Bill once more on YouTube saying, thanks for answering the questions. Impressive what you've done. Future of medicine is live streaming. It shows confidence.
Thank you so much. I appreciate it. All right, so you can see the tip of the dilator is approaching the tear. Again, let's confirm. This is 5-1-4-5-3-4. Everybody agree? 3-4? I can feel the herniation. You guys see that? Literally, the tip of the dilator is away from the disc by about 5 mm. That's because there's a huge herniation right here. And I'm pushing against it. You can't see the herniation on X-ray, but I can feel it. So first thing I'm going to do is shove the herniation back into the disc. Okay? Yes, seems odd, isn't it? But that's what we do. It's called the inside-out technique. You push the herniation back into the tear, and then we're going to go take it out from the tear. And let's show the audience one more time, Henry, how the Deuk laser disc repair procedure works.
Of course.
Shot.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see from our video on the Deuk laser disc repair just what we're doing right here with the laser. There's a tear in the wall of the disc called an annular tear, specifically a posterior annular tear, which is in the back of the disc. The posterior annular tear is where the herniation is stuck. It will not leave the posterior annular tear, and it sticks in there and causes pain. And that's what I'm here to clean out, those tears. He had 4 of them that were causing pain based on my physical exam, my interpretation of the MRI. And we are on the last disc. So cleaning up this disc on the left should be the end. This should fix his neurogenic claudication. It should fix his back pain from the discs. That's what I expect. Any questions?
Yes, we have a question coming from Lanu on YouTube,
Hello, Lanu.
asking, does every patient require a family member to escort them after the surgery?
The answer is no. Patients do not require a family member. You can have a friend. You can have actually a service like an Uber service that can stay with you and keep you company. So it just has to be an adult that stays with you after surgery. Doesn't have to be a family member. It can be a stranger or a friend.
We have another question
Yes.
coming from Raj once more on YouTube,
Yes.
asking, do you do brain surgery such as removing benign tumors? It would be fascinating if you were able to use a laser in the brain one day.
Yes, Raj, I do brain surgery. I'm a neurosurgeon. And can I use a laser to remove a tumor? Absolutely. Can I take out a tumor? Absolutely. We actually took out a benign tumor here at our surgery center. That's one that would get my anesthesiologist, Dr. Berndes, underwear bunched up. But yeah, we've taken out brain tumors. We've taken out spine tumors, intradural, extramedullary tumors. That was our very first surgery that I ever did here at the surgery center. Was Luis, were you were here for that or not? I actually had to open the dura and take a tumor out stuck to the spinal cord. And the patient went home like a few hours afterwards. No spinal fluid leak. Huh? What? No A-line? No, of course not. I don't lose enough blood for an A-line, ever. A-lines are for, doctors who don't appreciate or can't control bleeding. I mean, obviously, if it's a serious surgery, nah, never. Unless you have somebody extremely unstable, And there are people that are, but they're in the hospital, not elective. We would do A-lines all the time in neurosurgery for all kinds of stuff. Aneurysms and hypervascular meningiomas and, all kinds, but not spine surgery. I mean, yeah, fracture dislocation, right? Somebody in a high-speed MVA, they've got a complex thoracic fracture and they have to have a thoracotomy. We're going to put an A-line. But, you know, degenerative stuff, no, never. You know, but it's patient-specific, obviously. Managed a lot of A-lines as a neurosurgery resident in the ICU. A lot. A lot of people don't know that neurosurgeons training, we have to spend years managing ICU patients. People are very sick. And we do brain tumors, we do children's neurosurgery, kids with brain tumors and spinal deformities like spina bifida, Chiari malformations, and shunts, lots of shunts. But I did 7 years, averaged 110 hours a week in the hospital working, just like the other residents. Nothing special there. So, had a lot of experience managing patients with medical issues. And I can tell you, getting back to a comment that was made earlier, anytime somebody had pain, we would just call the pain service. They were called the pain service. And it was anesthesiologists and physiatrists. God damn it, Luis. Tell me if you didn't get it. I just put it back in. And they would come and they would just drug up the patients. That was 25 years ago. Things have changed. Now we have more invasive procedures they do, like spinal cord stimulators, injections, burning of nerves. All right, any other questions?
At this moment, no current questions.
Great, we're almost done. Got about a minute left on this disc. Then we're going to end this broadcast. So if you have questions, ask them now or join us on the next stream, which will happen 5 minutes after we close this one. And we're going to be doing bilateral sacroiliac joint Deuk plasma rhizotomies. All right.
We just got another question from Raj, once more on YouTube,
Sure, Raj.
asking, would you encourage anyone these days to become a spine/neurosurgeon? It takes so long to get qualified, and why did you become a neurosurgeon as it is in the UK? It's 15 years journey, I think. Thank you, doctor.
Yeah, Raj, you're welcome. Here's what I would, yes, the short answer is yes. Scope off. I would definitely recommend spine surgery. I love it. I love getting people out of pain. It's incredible. I love the challenges. And I'll be honest with you, 99% of back pain requires surgery to fix it. Same thing with the neck. Almost 100% of neck pain, I say 100% of neck pain requires surgery to fix the pain. So curing back and neck pain is not a pain management doctor's job. It's not done with pills or therapy or injections or needles. It's done with surgery. And we never understood that until now. I literally am changing the entire world's perception of how to cure back and neck pain. And it is a surgical problem, not a conservative therapy, pain management, chiropractor, massage therapist, pain pill problem, okay? And the reason is because the source of pain is literally surgical source. It needs a surgical treatment. So, is spine surgery have a very bright future? Absolutely. But don't do bad spine surgery. You know, don't get into like fusion and just do fusions because they pay a lot of money. Do what's right for the patient. So if you want to do what's right for the patient, I think spine surgery is great because there's a tremendous future for it. Okay, we're going to now move to another surgery. We're going to end the stream. We'll be back shortly.